Good morning, my dear students from SMCH Silchar, Tripura, Manipur, Guwahati, Jorhat, and also Dibrugarh. So welcome to this session of your spine. Today we will be discussing about the spine, various parts of the spine, particularly the anatomy, biomechanics. Then subsequently also cover up the subject like trauma and infection, particularly tuberculosis, and these are the spines. These are the planning of this our session will be covering in near future. So we'll take up the subject one by one. Before that, as usual, we have to go with a philosophy. So today's philosophy is a bahuni me vyakti dani danmata sajjana. Bahuni me vyakti ni danmata sajjana. Ye aapko yesterday we have talked about this slogan. That is, your Arjun was asking about the to Lord that how could able to give the lesson to Srijadevata who born earlier than before. Because he was telling to Arjuna that I given the lesson of conscience or the science to Srijadevata, then this percolating down to Manu and Ikshako like that. Now he is asking that Srijadevata is born before you, then how could you could able to give him lesson? Then he said that it is not is because I reborn and born. And I do remember what it was there in the previous born. That is what he is explaining this in this verse. That is what this slogan is. So now today we will be talking about the various parts of the spine. So spine, as you know, is the axial skeleton and is comprising of the vertebral. So as such it is, so it says your spinal column. While you talk about the spinal column, essentially it covers up all the things, not only the vertebra, but also the comprising structures that includes the discs, the joints, the neural structures, the ligaments, the muscles around, front and back. So many things are there. So we will cover up all these things, what is the importance. It is not possible to talk everything in details, but even then we must supposed to understand what is actual gross anatomy. So in this spine, as you know, that you have a whole spinal column is consisting of the vertebrae. So how many vertebrae are there? 33, 34, but it is there actually 26. Then your sacrum is comprising of 5. Then a variable number of the coccyx, which is a bit variable. Sometimes 2, sometimes 3, sometimes 4 like that. So that is the one part. Then a little bit of the development of the spine is also important. Let us talk with the origin, how this spine is being formed. You know, in the spine development, there are two components basically. One is the spine bone itself and another is the neural structures. And the neural structures is basically developed from the notochord. Yes or no? And it is said in the axial part, in the back, there is condensation of the mesenchymal tissue. Yes, in the early part, and this condensation is formed. That is basically mesenchymal, and this got called scleroderm later on. And this is this segmentations of which subsequently matured enough to become the vertebra. Yes. So ectodermal tissue plaque is formed in the cephalic area, which is invaginating into it as if pushing towards the balloon. A balloon, inflated balloon, while pushing, it is pushing like that. This is your notochord is coming from over. That subsequently develop into the spinal column. And a tissue which is already formed in frontal part is giving the body, and the another tissue which is on the dorsal side of the notochord is condensing to the appendiceal part of the, appendiceal means posterior part of this body. So basically in the vertebra you will see they have two. One is body part, another is your appendiceal part. Body part and appendiceal, and through his we have this your spinal cord is coming. Yes or no? That is the basic structure. So basically two components here. One is the vertebra itself. Another is your neural structures there. So in the vertebra you will find actually it has got three primary centers to form. One is center, one is above and down below. End plate. These are the end plate. One end plate here, one primary center, another primary center here, another primary center is the center. Body, primary center. In the appendiceal part you have 5 secondary centers to develop the spinous process, then tendinous process, then the joints. Likewise, so the 5 your secondary centers, 3 primary centers that actually gives the shape of the vertebra. So that is how it is formed. This is the formations of the spinal column, which comprises with your neural structure as well as the bony part. Bony part actually one is body part, another is appendiceal part, which is mostly formed by your 3 of 5 centers, the secondary centers, and the body part is mostly by the 3 centers there. Okay? So this is your how it is being formed. Now, as you all know, in the spine you have certain curvatures. On the AP view, this is being seen, that you can see also that if you see the spine from the front, it is a straight line. On the other hand, if you see from this left side, so you do have 4 curves. Yes or no? Cervical lordosis, thoracic kyphosis, again lumbar lordosis, and actually the sacrum is again kyphotic. Yes or no? So if you go back in the newborn, do you have all these curves develop? In the newborn, you do not develop this sort of curves. The only curve in the newborn is the C-sepal. It is basically C-sepal. Yes? That means it is a single curve, only one. All these things are developing in the subsequent period of time. While the newborn starts doing crawling, while the neck becomes steady, crawling, at that time he develops the cervical lordosis. Okay? Subsequently, when the newborn starts standing biped, there is developed the other secondary curves like your thoracic and the lumbar. Yes, so this one your cervical lordosis, another is your lumbar lordosis, and in between the thoracic kyphosis. So, and this all the secondary means your in this the others are your all secondary curves. They are developing. Actually, they are compensated to each other. Their secondary curves are developing by the age of your 10 years. By the age of your 10 years, they used to develop this part, secondary curves. So the initial curve is your C-shaped one. Subsequently, they develop this S-shape. Initial phase, it is cervical lordosis. While trying to stand, they develop the other curvature as well, thoracic as well as lumbar. Yes, so this is how the curvatures is formed, and these curvatures actually give the more strength to the spinal column itself, and particularly while doing jumping and other things, it has got more resisting power than that of a straight one. In this straight, the resistance power is a bit less than it is curved, which can absorb better strength, better load on it. That is why this curvature is also important for taking load. Yes, sir. So that is your basically these curvatures, the important curvatures, how it is formed and how. Normally in the thoracic curvature it is said around 40 degrees, or 20 to 40 actually. And lumbar area it is twice the that of your thoracic area. Getting my point? So this is twice the that of your ratio wise. This curvature is a bit long, but it is short, compensating this curvature, and that is why you have twice the ratio than that of your thoracic one. ঠিক আছে? Cervical lordosis also is important, and this is being reflected by the presence of your K line. We will talk about the K line later on, how this curvature is essential for particularly in degenerative spine, how it is important, how is maintenance in radiology, that is called K line. That is another thing we will talk later on. We will take later on. Yes. Now, furthermore is that you know that if you talk about the individual vertebra, we will talk certain important vertebrae, not all. Which are the important vertebrae? The vertebrae in the craniocervical junctions are a bit different. The craniocervical junction, now that is your curvatures. Then we have so many things there in the muscles and the ligaments. So, okay, we will talk about little bit of your ligaments also and muscles also subsequently. But let us talk about the vertebra first. How the vertebra is formed, we have discussed. Now, in the cervical spine, we actually have three types of vertebra. One is your C1 is a bit different. C1, all we know, this is different vertebra, C1. C2 is a different vertebra. These are atypical vertebrae, but C3 onwards, up to C7, they have got similarities of the vertebra. The C1 is also known as atlas, which is important for articulations with that of your skull. So this joint is important, and this vertebra is devoid of any body. This is interesting. That is why the C1, C2 and C3 onwards. So there are three groups of vertebra in cervical spine. The C1 is a bit atypical vertebra. It's devoid of any body. But this part is called lateral mass. Okay, we invariably talk about the lateral mass in the cervical spine. Let us talk about the anatomical part of the cervical spine first. Then we will go to thoracic and lumbar, individual vertebra. In the cervical spine, as I said, C1, C2 and C3 onwards. C1, and also I said that this is called lateral mass. How do you define lateral mass in the cervical spine? Lateral mass is a part of your, yes, you must have a good conception of the part also. Those things which are anatomically and surgical point of view important, we will emphasize this part, not all the general thing. The lateral mass is the part in between the two articular surfaces, and this is a significant thing. Invariably, this mass is very important, particularly fixation of the cervical spine from posterior side. Cervical fixations in the posterior side mostly, conveniently and routinely done in the lateral mass rather than the pedicular fixation. Yes, pedicle fixation in cervical spine is also done, but it is more risky because it is in between two important structures, vertebral artery and the cord, and in between you have the very narrow zone, and of course some experts used to do, but most of the surgeons used to do the fixation in lateral mass. And you must have no knowledge that what is called lateral mass. Lateral mass is a part in between the two articular surfaces. This is called lateral mass. And if you see from the lamina, if you go laterally, this is the area where you have this lateral mass. And then above you have the superior articular surface, inferior articular surface. This is one important thing in the cervical spine, one point. And the identification of the cervical spine vertebra is invariably done with the foramen. In the transverse process, you have the foramen transversarum, which is an important thing. A very vital structure is going to the vertebral artery, ascends up to supply the brain. Yes or no? Yes. So these things always demarcates and is a classical one to be differentiated from the other vertebra. This is smaller in size than that of your other vertebrae. Now, can anybody tell me why the cervical spine vertebra is smaller than that of your lumbar vertebra? The basic, very simple reply is that since this vertebra need to take less weight than that of your comparative part of your lumbar area, so necessarily it is smaller. This also should come to your mind that why all the vertebrae are not of same size. Not of same size is also, it is because of the fact that progressively you go, you will find the cervical vertebrae are smaller, thoracic are somehow bigger. Then again down below you do have this lumbar vertebra which is biggest of all. Yes or no? So this is all because of the fact that progressively this vertebra bearing weight and then taking load indicates this size also. This is correspondingly increasing in size. This is an interesting thing. It is an interesting thing actually to observe. As you know, the spinal cord, spinal column, what are the functions? One or two words about the functions also. What is the function? As you all know, it gives the axial skeleton on which we are standing. The biped animals, we are actually quadruped earlier, then we became biped. So this is the axis on which we are standing. Yes or no? It essentially gives the support to the skull above. Yes or no? Skull above and taking the load of the other structures. It also gives the protections to the neural important structure, that is your spinal column, spinal cord. Yes or no? Then in the thoracic area, it is giving articulation to the thoracic case, which is an important structure to give protections to the vital structure like heart and lung. Yes or no? This is also giving articulations. In the abdominal part, particularly the lower lumbar, the lower thoracic and the lumbosacral junction, this part is giving attachment to the important structures, so ligaments and your fascias and the muscles for the abdominal cavity, and down below for the pelvic organ. Yes or no? So many, yes. Besides, it also gives us the locomotion, means movement in many axes, flexion, extension, rotation, lateral bending, so many things. Yes? And also helps us to do all the activities like jumping, like your running and other thing, where it also acts as a shock absorber, particularly discs, which are the important structure to act as a disc. So grossly, this is the function of the spinal column itself, which is important. We are providing the stability, protection to the important structures, and also give us the mobility of all these things. Yes? Now coming back to your C1, you already discussed, they devoid of your in the body, and this is articulating with that of your occiput. So in this area, if you consider this joint here, C1 with occiput, sometimes people used to go C0, C1 joint. As such, this area is known as craniocervical junctions, which include the occiput, the C1 vertebra and C2 vertebra. This junctional area is an area where the neurosurgeon also used to play their role, and the orthopedic surgeon also, they used to play their role. So both these people are working there. Craniocervical junction, it will be difficult to understand sometimes, and I would like to one or two words here. That is the area where the ligamental structures or the soft tissues are playing more role rather than that of your bony articulations. So that is why I would like to add 1 or 2 points here also, because important things sometimes come in between. That is why I should tell you that this area radiological evaluation is very difficult. Because in a trauma situations, in particularly the craniocervical junction, it is not very easy to delineate with the existing X-ray, existing CT scan, existing MRI also. Sometimes we used to take the help of different ratios. We'll talk about the ratios later on. We'll talk about the axis of the spine, cervical spine. We'll talk about this. Why this point is important? I again emphasize that this part is mostly dependent upon the ligaments, soft tissues, and the membranes and other things. Here, bony joints are a bit less important. And in a trauma situations, it is not very easy to delineate these structures with the help of the existing radiological tools. So that is why in certain situations we take the help of different ratios. We'll talk about the different ratios, power ratio or other things later on. What is the importance of this and why is it being done, and to evaluate particularly in trauma situations these locations. This area, particularly this area and down below craniocervical junction. This joint is mostly important to the flexion and get a range of your doing this moment. Particularly is the C0, C1 joint. Yes? So craniocervical junction is very important. You have this. On the other hand, another joint we are not having the odontoid here. C2. C2 is there. Okay, fine. You know this is another different type of your vertebra, which is not similar to that of the other vertebra, where we have a projection like this form a C1, C2 junction. And this area is having 3 joints here. One, this is joint odontoid process, then 2 joints here, but there is no disc. And here this joint is mostly are responsible for rotational purpose. Rotation. So this is flexion extension and this is your rotational part, right? And subsequently under other vertebrae, subsequently these vertebrae are important to do the flexion, sometimes rotation also contributed, but grossly the flexion extension of the neck is mostly this one, rotation is basically this one. Okay? So this part is a bit not similar to that we have odontoid process. We have the lateral process also. Lateral mass are very big in C2, and spinous process is also relatively bigger. Sometimes it's almost similar to that of a C7, which is very prominent one. And C2 spinous process is very important in the sense that it gives the attachment of the very important muscles. That is why in surgery, while doing exposure from the posterior side, I am talking some important thing also in surgical point of view, that this part, particularly C2, they have a crucial types of your muscle attachment there, posteriorly. This is very important to provide the stability of this part. So that is why, while doing the surgery from the posterior side, detachment of the muscles from the C2 is discouraged. Whereas you can do excision even the C3 onwards. So C2 is a bit less task because of the important muscles. They are playing their role to maintain the cervical lordosis and also stability of the cervical spine. Yes, this part is understood. This is important. Then C3 onwards down below are almost same vertebra but increasing the size. Body of the is increasing. Pedicular size is also becoming more. Then, but all are having a foramen transversarium to be the hallmark of identifications of these vertebrae. Then next coming is thoracic vertebrae, which are also bigger in size, but here this spinous process you see it is downwards. We do have the articular surface. Here, another important point I would like to add here that these articular surfaces in the C3 onwards down below, C7, you also try to see the articulations of the joint of two adjacent vertebrae. And what is the shape? You will find very interesting that in the cervical spine, the joint articular surface is a bit like this, a 30-degree angle. That is why the axis of the diversion like that. But if you down below go, then the thoracic area you will find there is almost this line, anterior-posterior. Are you getting my point? See, in the adjacent to vertebrae, I am talking about the joint also. I am talking about emphasizing the importance of the joint also. In the cervical spine, the joint is a bit different. And the thoracic spine, the joint is a bit different. As such, two adjacent joints are joined by three. One is two diatrial joints, yes or no? And the intervertebral disc in between. And this component is also known as what? Anybody who can say? Mobile unit or functional unit of the spine. This functional unit is applicable throughout the spine. This is called as if your nephron of the kidney. Functional unit. Just like this terminology which is applicable there, here also this part is known as functional unit of the spine. That is also an important thing. So you have to remember what is called functional unit of the spine. This area, as I said, adjacent two part, disc and also the diatrial joint. This part is called functional unit. Because all the movement and other things are there, the stability and other things are there. This is called functional unit. I am again coming back to the joint design. In the cervical spine, the joint design is different. It is oblique. But here in the thoracic spine, it is anterior-posterior. So while there is a movement there is opening up the joint like this. But there is hardly any movement. There is a rotational, there is a little bit of rotation. So this joint design is such that it does not give much movement of the joint. Had it been oblique, their joint movement is more in the cervical spine. But this joint design does not allow much movement. So that is why this joint design as well as the engulfment or your attachment of the cervical ribs make the thoracic spine relatively stable, less mobile in comparing to that of a cervical spine and the lumbar spine. This should be understood. So you know, whatever movement taking place in the spine, it grossly either movement in the cervical spine or in the lumbar spine. Very little movement is there in the thoracic spine. Why so? It is because of the design of the joint, one. Number two, it is attachment with this your ribs case, which make it relatively more stable rather than movement. Yes, but the joint design in the cervical spine gives enough room to play with the flexion, extension. So many movements are possible there. Lateral bending, flexion, extension, rotation, right rotation, left rotation, so many things are there. So all these things are possible. And to some extent, it is more in the lumbar area also, but relatively you do not get much movement in the thoracic region. This is another important point. And the joint. And the spinous process you feel that is prolonging towards the caudal side. It is extending towards the caudal side. Yes, sir? Again, you come to the lumbar area, you will find it is different. The joint is, see, the joint was like that. Now his joint is now in lateral plane. See, this is the joint here. So if you articulate two lumbar vertebrae, you will find the joint design is now changing. Joint design is now changing. It is bigger and smaller. Joint design is changing. This is the articular surface. See, I am talking about this articular surface. See. This articular surface, see, in the lumbar area, what is the design? This is somehow like this. But In the lumbar thoracic area, it is like this. Yes or no? So in this case, it is opening up, and opening up is more common. Whereas in the lumbar area, this joint is giving more room to play. Because the joint design is so that you have a better range of movement there in the more range of movement in the lumbar area. So that is also a point it should be remembered, that what is the joint design and what are the range of movement possible because of it. So joint design in the cervical area is different. Joint design in the thoracic area is different. Joint design in the lumbar area is different. So many things are there, but you need the observations. Yes? Then a little bit of your discs also. In the joint, you know the diagonal joints are there, two sides. I am not deliberately not talking about the various components of the vertebra also. These things you all know. I am touching the salient important points. Not going to all the details for this tendrous process, pedicles. But one or 2 points that one should understand, that you are supposed to have this idea what is this pedicle. Where a pedicle is the junctional point between the body with that of the appendiceal part. Yes. And often you also know the pars interarticularis is, this is the pars interarticularis here. This is the pars interarticularis here. Yes. And this part is your lamina. So you have to have good idea about different parts. Other point is spinous process, transverse process, articular surface, superior surface, inferior articular surface are the common thing you're supposed to know. But I am talking about the more important salient point, what is pedicle, because you know every time you talk about the pedicle screw fixation, you're supposed to know the pedicle is here.
Pars interarticularis.
Pars interarticularis is between the two articular surfaces. The area between two articular surfaces, your pars interarticularis. You are supposed to understand that part. And the cervical thoracic area vertebra is that you have a articular surface, additional articular for the ribs. So that indicates how to differentiate cervical spine. It is designated because of the presence of your 10%. Thoracic area, it is designated by the additional articular surface for the ribs. And lumbar area is no foramen or no extra articular surface, and bigger in size is your lumbar vertebra. So this is your grossly individual vertebra. Now let us talk something more than that. So every vertebra in between, you know, a disc is there. In between two, we do have a disc here. This is called intervertebral disc. Intervertebral disc basically having two components. We all know. There's outer part, your annulus fibrosus, and gelatinous soft is your nucleus pulposus. And both of them are important because one is like the cover which is engulfing the gelatinous substance inside. Now what is the function of it and how it is surviving? Two treating points. And this is also a joint. Basically this is a part of your mobile unit of function unit of the spine. So gelatinous middle surface nucleus pulposus has got enough water. Yes or no? Collagen tissues. And this is important for what? For your equidistributions of the weight, and also has got the functions of doing movement. Yes? Equidistributions of the weight throughout the end plate. It can distribute the weight because when pressure is generated on it, it imbibes water and distributes the weight throughout uniformly to the end plate. Then besides it also maintains the height of the vertebra. Almost 1 to 1/4 is coming from the disc. Whole length of your 61 to 71 centimeter, particularly male or female. And then out of which 1/4 is being contributed by this disc. And the disc size is bigger in lumbar area, almost 9. And if you go above, it is reducing to 5 at thoracic area and 3 to 4 time even in the cervical spine area. So I am talking something about the disc. It is comprising two components, nucleus pulposus, annulus fibrosus. Annulus fibrosus network is just like your lamina, just like your tire. Tire you have, if you see the tire of the they are network like this, in the middle, like this, in this axis. Many layers are there, sometimes you say the 25, 28 like that. These layers are important, and when there is a load, there will be horizontal in the cell. This become horizontal. And this is important to hold the nucleus inside so that it is not tearing off, it is not propagating out. And it also adhering these two vertebral end plate. So end plate is here. End plate is also a cartilaginous part which is about 1 mm in thickness. And it is supported by the subchondral bone at which you have a vascular network. This vascular network is responsible for supplying the ends of your disc, nucleus fibrosus also, to some extent, but mostly it is dependent on the diffusion technique of nutrition. Diffusion technique. So nutrition is coming from the diffusions. As such, there is no nerve, no arterial supply there, but it is surviving with the diffusion technique. Diffusion. Yes? So this is a rough, gross idea of the hair. Now little bit of your ligaments also. What are the structures holding it? As you all know, that you have the anterior longitudinal ligament anteriorly. Yes? Then another ligaments we see their posterior part of the body is the posterior longitudinal ligament. Then you have between the two lamina we have the ligamentum flavum. Yes? Then the joint capsule is also an important structure to hold it. It is a synovial type of joint. Then in between the two spinous processes the interspinous ligament. Then on top of this spinous process is the supraspinous ligament. So these are the important structures of holding each other from anterior to posterior. Again from posterior side supraspinous ligament, interspinous ligament, ligamentum flavum, the capsules, the posterior longitudinal ligament, then anterior longitudinal ligament. All the important structures are important. And while we talk about the PLC, we talk about the PLC means posterior longitudinal ligament complex, which is an important thing in maintaining the stability and is a matter of concern, particularly in the case of trauma situations, where to intervene surgically or where to not, depending upon the involvement of the PLC. Yes, that part is covered. Then next point is that what is your columns? You know there are 3 columns. Whose column? Dennis column. So we all know about the Dennis column. Let us refresh ourselves. Today are the anatomy day. So we are talking about the various anatomies here. So your anterior column you all know, anterior longitudinal ligament, part of the body, part of your ligament disc, half, anterior longitudinal. Then your middle column is comprising the posterior part of the body, posterior longitudinal ligament, disc, posterior. Then that is middle. And beyond that, the joints and all the structures is your third, posterior column. So these columns are also important, and while defining instability, it essentially says that this middle column is involved means it is unstable. Any 2 columns involved means it is an unstable situation, as far as Dennis concept of instability is concerned. So do we have this is the point, and a little bit of your spinal cord. How many arteries are there? Peripheral nerves. You have 31 pairs. 31 pairs of peripheral nerve. Though the vertebrae 33. You do not have a 4 above. And this is your foramen. This is your foramen through which these roots are coming out. This is what? Intervertebral foramen. This is vertebral foramen through which it is forming the canal for the cord. This cord is ending at the level of L1 vertebra, which is called, what is this known as? Conus medullaris. Subsequently, you have the formation of your equinus. Yes or no? Corda equina, tuft of your roots are coming there. Little bit of your cord. We are talking about the cord. If you see very carefully, it is interesting thing to look for. The size of your vertebral canal, this vertebral hole, is bigger in cervical spine, a bit lower in that of your thoracic spine, and almost medium in the lumbar area. Why so? This is also important thing to look for. This is about the size of the foramen, vertebral foramen. I am talking about intervertebral foramen also for the root. Now, little bit of this cord. Little bit of the cord is that, you know, the ends of the L1. In children it is down below. But while it progresses up, it comes up and again it is L1 vertebra. That is the important thing. And also tuft of your roots. This is called phylum terminally. I mean, this is phylum terminally ending here and a conus medullaris, then your equinus. Equino means ghora, means horse. That is all the roots are coming for the combinedly from the level. But that is all you know. But what is more important to understand here, another thing, that is occupancy of the cord inside the canal. What is the meaning of this? 1%. Yes. How much cord is being combining inside the cord? This is also has a very important implications when the trauma is concerned. So the occupancy of the cord inside the canal is very important. I am giving a very good example. See, if the injury is at the level of thoracic spine area and an injury in the lumbar area, where the chance of injury of the cord will be more? In thoracic or lumbar? It is in the thoracic area, not in lumbar. Why so? Because in the lumbar area the canal is so wide, the occupancy of the neural structure is a bit less considering to the canal, so it has got more accommodative power. If a huge disc which is coming may not cause a reflecting the neurological deficit. Whereas a small disc at the thoracic area, lumbar thoracic area, may cause a significant damage to this cord. Important point. This is the importance of your occupancy of the cord. It is said in the cervical 35 to 50%, and thoracic area is occupancy is more, occupying more. Lumbar area has got a wide treasure to cover it. So in rest of the part, you do have the cerebrospinal fluid, the meninges, you have the epidural fat and other things, which are cushioning effect. So that is also, if you understand the extensivity, possibility of extensivity to the cord, depending upon the occupancy. Yes, this is called occupancy of the cord. This is also interesting point to note that why there is more significant injury thoracic area and less in the your lumbar area. Yes, that is another point. The other rest of the part is being occupied by the epidural flesh and cerebrospinal fluid and the meninges. 2 points. And another one of again important point is how it is getting the nutrition, the cord. You know, you have the three actually vessels. One is anterior spinal vessels, two posterior spinal vessels. These are the contributory factor. But what is more important, anybody? In thoracic area, there is a single artery which is more contributing at the level of your D7, D8 like this, which is supplying the down below, the Adam Puis, artery of Adam Puis. This is an important thing to look for while doing some surgery or trauma at this level. Sometimes the patients may come without no significant finding, nothing, but he is developing a sudden onset of your paraplegia. Probably it may be because of the vascular injury in relation to the your injury of the Adam Puis. So these things are also important. Where that is your in cervical spine and this is arterial supply, and the importance of the Adam quiz, the importance of the anterior vessels, importance of the posterior vessels, and you know the venous drainage is mostly done by the Benson's plexus. The importance of the Benson's plexus is all depends upon the gradient effect, no valve. As such, you do have the valves in the vein for drainage in the lower limb, you know, valves are there, while there is your varicosity. But here it is important that this flow of the blood is dependent on the pressure gradient rather than valve mechanism, no valve. That is why sometimes infection may come from above, down, down, up, because there is no door systems there, but there is an open technique, and this flow of the blood is dependent upon the your pressure gradient. So, this is here today. Actually, I intentionally not work the clinical subject today. Today, we wanted to tell you about these various curvatures, the various vertebrae of the cervical spine, thoracic spine, lumbar spines, the ligaments, the various movements, the stability we concern about these ligaments, the occupancy of the vessel, occupancy of the cord, and its surgical importance, and the most stressing point is that is craniocervical junction, etc. So we are limiting for today's. We will talk the subsequent things. Do you have anything to ask? If you do have, we will try to discuss.